We can hear
Thank
you,
you.
sir.
Thank you for the nice introduction. There's a slight glitch, as it always is in my online presentation, so there'll be some slow movement of slides. My friend there locally will be changing the slides for me. So today I'll be talking about PET-CT in vasculitis, and the talk will be mainly about FDG. Next slide, please. A little bit of background. Basically, there's an injury in the endothelium of the vessels, where the T cells and the monocytes, they actually infiltrate. There's a background of systemic inflammation which leads to endothelial damage and inflammation, and that's the process which is underlying the vasculitis and inflammation within the vessels. Next slide, please. Now, this is a long list of radiotracers which have been used for imaging of vascular inflammation, and you can see there's a whole lot of radiotracers. This is sort of tradition of nuclear medicine, that we can prove that anything can go anywhere and everywhere, everything can be seen with everything. In the end, it produces a lot of publications and research papers, and also generates a lot of confusion. Here we have FDG as the main tracer being used for inflammation. Next slide, please. Now, this is a nice publication which actually shows the pattern of involvement of the large vessels, which is indicative of what sort of diagnosis we are looking at. This red scale here actually shows that, if there's 100% involvement of these vessels or there's no involvement. So this first image is about the cranial giant cell arteritis. This is the large vessel involvement in the aorta and the subclavian axillary vessels, and in Takayasu's there's possible involvement of the renal vessels as well as the pulmonary vessels. So pattern recognition, as we know, everywhere from bone scan to all of the nuclear medicine imaging, is helpful in actually directing our diagnosis towards a certain vasculitis. Next slide, please. This is a busy table. I've put it here because it's a good table. It makes my task easy, difficult for, I guess, the audience to read, but it's a very good review article. Next slide, please. Okay, so here we have got these types of vasculitis in this column, but there are 4 different modalities: ultrasound, color Doppler, CT, MR, and FDG PET-CT. So there are peculiar patterns in each of these modalities by virtue of what this modality has to offer, which actually direct us towards the diagnosis and assessment of vasculitis. Next slide, please. I've added PET-MR at the bottom because of course, new data is coming up. So in this slide, you can see the examples. On the top side, this is actually a halo that we see on the ultrasound for vasculitis. Here in the middle, we have got this thickening of the aortic abdominal aorta wall, representative vasculitis. This is actually a stenosis, and it can be seen nicely in the sagittal view. In this bottom, we have got 3 images from the PET-CT, nice donuts involving the ascending and the descending aorta. This MIP view shows the entire extent of the aortic involvement, carotids as well as the subclavians, cut through the base of the skull as well. In this image on the left side, there's involvement of, there's a secular aneurysm. And at the bottom, we've got a few images of the MR as well. Again, we're looking at the thickening and the enhancement of the thickened wall. Next slide, please. This is a paper particularly about the imaging features of PET-CT and vasculitis. And you can see, as we saw in the previous image, there's a nice involvement of aorta all through the extent from the thoracic up to the upper half of the abdomen, almost up to the bifurcation. Patient presented with fever of unknown origin, and vasculitis turned out to be the cause. There's also involvement of the temporal arteries here. These are difficult to see because there's a lot of background activity in the brain, and there's also involvement of the vessels down in the pelvis. Next slide, please. Now, apart from these, the involvement of just the vessels, there's a lot more which can be seen as part of the FDG PET-CT. For vasculitis, of course, on the top again, we have got the aortic arch involvement, the celiac trunk, and in the gut, there can be ileocecal involvement in this particular case. Lungs, they are affected by vasculitis. Kidneys, a dodgy area because there's so much physiological excretion going on. But again, in the case of patient presenting with symptoms of renal function, it can be part of the spectrum of vasculitis. sinuses, and the mastoids. So now on this image, I will just mention, I came across a very interesting paper recently looking for something else, and they used the word cartography, which is actually the science of making maps, and they say there are two cartographic imaging mapping tools to look at a certain thing, disease or abnormality, and they actually named PET-CT and bone scan for that matter, because that was a whole body scan. So this is like, when we are imaging for one particular disease, since we are imaging the whole body, which essentially usually takes from vertex to the upper thighs, we are actually looking at mapping the whole disease, which no other modality can do it in that, amount of time. Next slide, please. Now, all that glitter is not gold. We know that very well in nuclear medicine. There can be mimics of vasculitis, infectious disease, inflammatory disease of different syndromes and diseases, different organs, different spectrums of disease, connective tissue disease, congenital vascular disease, as well as neoplastic disease is always there to overlap anything in Pakistan, a background of subcontinent and the developing world. TB is always a factor. So basically, we have to know what we are looking for. So the background, the clinical history is most important, and that helps us decipher the patterns of uptake towards a particular diagnosis. Next slide, please. Now, as I mentioned about cartography, there's incidental findings which we are always able to see on an FDG PET-CT scan. Over here, we see a lot of second primaries while diagnosing for one malignancy we end up seeing in the gut and other places. This is a recently done study in which they actually showed that the incidental finding on FDG PET-CT for large vessel vasculitis, the incidence of incidental finding increases with age. Of course, there's a more chance of having secondary malignancies or other causes of ailment which are coming with age. So this is a good recently published paper. Next slide, please. Now, in this example, the red arrows actually show the involvement of the vessels for vasculitis, while there was an incidental pick of the left-sided pheochromocytoma. Next slide. Now, since we know that FDG is a tracer which is being used for vasculitis, it's useful, there's clinical data behind it. Now, the effort is to actually standardize how it is looked at and reported across the world. Lately, there's a nice trend that there are consensus between different organizations, as well as under the ambit of IAEA and in some cases WHO, to come up with a consensus, as much a consensus can be created, so that we are all listening to the same song and speaking the same language as much as possible. So based on this, there's been a consensus document 2018 regarding how to be evaluating FDG PET-CT for vasculitis. Next slide, please. Now, as far as the preparation for FDG PET-CT is concerned, is pretty standardized. There can be a fatty meal to reduce the myocardial uptake. Glucocorticoids are critical because, of course, once they are kicked in, and they have to be started because of clinical reasons, the ability of FDG PET-CT scan to see active disease can be, sort of compromised. A study has been done which shows that there can be a 3-day window once the glucocorticoids have been started when FDG PET-CT can be done. So ideally, before the start of glucocorticoids, if not possible, within 3 days. If not possible, then do it and let the clinicians know that there's a probability of false negative results because the patient was already on steroids. Next slide, please. Now, this is the pattern, sort of key which has been provided. We are familiar with Doven criteria for lymphoma. It always helps. And in this, you can see that, of course, the reference uptake is in the liver. Low grade, which is graded as 0 is no uptake. Grade 1 is when it is higher than the mediastinum, but lower than the liver. Intermediate is equal to the liver, and high is significantly higher than the liver. And you can see in the top images that this is low grade, this is medium grade, and this high grade uptake is, quite avid. Nice visualization of the large vessels. From this, they have come up with a total vascular scoring system as well. There are seven different sets of vessels which are allocated a number, which can be from 0 to 21 for grading this. But this is clinically, basically, we're reporting grades, not the scores at the moment. Next slide, please. Polymyalgia rheumatica is closely associated with giant cell arteritis. So this guideline about standardizing reporting of FDG PET also included this criteria, which again is graded as mild, moderate, and severe. And we're focusing on the joints, the synovium, and the soft tissue around these joints for PMR. Next slide, please. PET-CT angiography, as Dr. Kessler also mentioned, with PET-CT, if they add angiography, fully enhanced, contrast enhanced angiography, we can provide more information, putting together the enhancing features of a CT angiogram with PET-CT FDG uptake. At the moment, it's recommended for research, but it is there. Next slide, please. Now, this is a schema to look to work up a patient for large vessel vasculitis. At the top, you can see a patient over the age of 50 years with cranial symptoms. The first thing is to have a temporal artery and extremity ultrasound. If that's positive, giving you the halo sign and peculiar features of vasculitis to go towards the diagnosis. If it's negative, the next step would be a PET-CT, an MRA, or a CT angiogram, which would lead toward the differentiation between a large vessel or a giant cell arteritis. Between these two, above 50 years and less than 50 years, in the less than 50 years, because of Takayasu's, the head and neck and extremity ultrasound is done, and of course, the pathway otherwise is directly towards diagnosis, or going via MRA, PET-CT, or CT angiogram. Next slide, please. A few clinical scenarios. On this one, like case 1, a patient presenting with the cranial presentation, 73-year-old male. He's got symptoms of lethargy, myalgia, weight loss. It has to be fast-tracked towards a specialist review. In case 2, there's a mention of red eye, a right eye, reduced visual acuity. This is much more critical than the other one. On this left side, we've got 2 cases of primary systemic large vessel presentation. Again, weight loss, fatigue, myalgia. The concern is for large vessel, and in this one, in the case number 4, we have got uneven upper limb, blood pressure, absent right arm, radial pulse. So there are different clinical scenarios. The thing in blue here is fast track specialist review, urgent specialist review. I put the slide here with one other reason that, this actually shows how we need to coordinate. The request has to come from specialists dealing with the vasculitis, and then of course it has to go back. So, it's good to interact with the referring specialists in particular disciplines to make best use of the modality which we have at our hand for diagnosis of vasculitis. Next slide, please. Now here, I put the slide with the emphasis on the treatment options at the bottom. In the last row, you can see these pink boxes: treatment with glucocorticoid and glucocorticoid sparing agents, immunotherapy, methotrexate. FDG was always there, been there for quite some time. What has made it useful for vasculitis? Treatments. Once we have treatments for certain things, treatments with good outcomes, imaging and diagnostic modalities become very crucial. Next slide. Now, treatment monitoring. Now, for diagnosis, FDG PET-CT has a sensitivity of around 75% and specificity around 93%. For treatment response, the initial thought was we'll be able to see that hot thing, the whole theranostics phenomena, and when it will not be hot, we'll be saying it's settled. It's not that simple. The next slide. There are many factors in play, and the sensitivity stays around 77%, but the specificity drops to almost 71%. Reason, like we see in bone scans, the patient responds to treatment, but the uptake might just still be there. Similarly, in vasculitis, there are factors which have caused the fluid tracer to get there. All those factors do not get sorted with treatment. So the uptake might be still there when we are looking at scans. It would reduce. So essentially, the idea is that FDG PET-CT has a moderate accuracy for distinguish active disease from remission in patients on treatment. FDG PET-CT scans have to be interpreted in the context of clinical and biochemical findings. If the patient is fine, biochemical markers are actually settling in towards normalization, the scan findings will be residual or reactive. If the patient is clinically unwell, markers are up, we have a scan which is still showing uptake, then of course that will be interpreted accordingly. That's very crucial. Again, collaboration with the clinicians. You want to have the history, why you are doing the scan, at what time you are doing scan, what is the timeline of the treatment. It's not always easy to stop all sorts of treatment 6 weeks before to do a PET-CT scan with FDG. So, it's a complex situation. It's not that simple. And basically what comes into play here is experience. Next slide, please. Now this is a case of a longitudinal follow-up imaging with FDG PET-CT. Initially, patient had extensive disease, entire aorta and the subclavians. With treatment, some response, some activity is still there, and towards the end, there's still some residual patchy uptake in this involved vessel. Crucial thing: what was the patient actually experiencing, and what the markers were showing at that time when this last scan was done. Next slide. Now, just moving towards the conclusion, this is a review article from Dr. Lavi and team, and this nice schematic picture shows that in the FDG uptake, in this whole development from healthy to complicated lesion in the vessel. Initially, when it is developing, there's increasing uptake of FDG, but then when calcification starts settling in, we have another PET tracer, sodium fluoride, which can actually be taken up avidly by the calcium, and that can be of help in looking up for coronary atherosclerosis. Next slide. Now, finally, this is another editorial from Dr. Lavi and team from 2018. I think it was started emphasizing about the role of FDG in infectious and inflammatory disorders without getting into the whole data that they discussed. One of the main points that Dr. Lavi and team asserted that it may be appropriate to portray the introduction of FDG PET to medicine as compared to what X-ray did to it, because now we have tracers which can actually, look into anything and everything with the right perspective and the right clinical scenario. Next slide. To this, I always like to add this comment from Thomas Baer, who is a physicist based in Austria, and he said that science and technology has delivered, and he was talking in terms of hybrid scanners and the radiopharmaceuticals which are coming up since then, and up to the physicians to make use of it. So the importance of this point is that nuclear medicine requires more physicians, more technical staff, more scientists to deliver what we have actually in our hands for a vast spectrum of diseases and illnesses, oncology, cardiology, and beyond. Thank you very much. This is a picture from Petra, which me and Dr. Shadi attended recently. Thank you very much. It has been an absolute privilege to be presenting to this PSN and 8th Congress. I'll be happy to take questions. Thank you.